نبدأ.
بسم الله الرحمن الرحيم والصلاة والسلام على أشرف المرسلين. Assalamu alaikum wa rahmatullahi wa barakatuh. I hope my voice is reaching everybody clearly, and I'm quite happy to have me in this kind of meeting in the educational activities of the Accident and Emergency Department in Prince Sultan Hospital. I'm going to speak today about a certain topic which is the times being seen frequently in the casualty and the GP clinics. So I'd say we will start by talking about the painful anal conditions, and that's usually being seen in the casualty or the accident emergency and the GP clinic so frequently. I will start my talk about some study had been done starting on the 2017, and that was in France by some team led by Geraldine Turno. And they have worked on, I'd say, 1,400 patients or 1,300 patients, and they found that around 15.7% of the presentation to the GP clinic and the casualty is emergency anal cases. And out of those 15% or 16% almost, around only 35% of them is being examined and 65% are not examined. Why they are not examined? There are too many things, either from the physician side or from the side. That around from those examined anal complaint or so, 45% of them are due to the reluctancy of the physician to examine the patient locally or to examine the PR examination. My connection is fine. Okay. And around 20% of them are not accepting the examination. As I have mentioned before, that examination is being refused by the patient or not being done by the doctor, and that's definitely making the diagnosis only 20% of the cases. While on the 35% of the cases which are being examined properly by the GP or the ER physicians, 80% of the cases are well diagnosed and only 20% are not diagnosed. So this is very important, to be honest, to examine the patient with anal complaint, not to be reluctant to do it or to do the examination. As I can see times from my work in Prince Sultan Hospital, that some patients are being transferred to the clinic or the general surgery clinic without being examined. And I have been surprised sometimes by a patient diagnosed as pilonidal sinus while he is having some sort of fissure in anus or sometimes prolapsed piles. That means that it is not examined or the patient is not examined properly. So examination of the anal area is very important, and we cannot rely only on the complaint from the word of the patient. So this is the completion of the study, and we were talking about the most common presentations for the most common reason for consultation. As I mentioned, the most common presentation or reason for consultation is the pain or the anal pain, followed by the bleeding and the anal swelling, which is consisting around 48%, followed by anal pruritus or anal itching. Sometimes we are representing it as itching around the anal canal or the anal verge, around 44%, and that's definitely a good percentage of the presentation. And the least is the anal discharge, which is around 1 or 4% of the cases. So the main presenting complaint or the main presenting reason for consultation will be the anal pain. What are the most common causes and how can we schedule the skeleton in our head? Usually, if it is only pain, which is presentation, we have to think about the anal fissure. We have to think about some viral infection around, like anal herpes or ulcerative proctitis. If there is pain and bleeding, we have to think about the anal fissure and proctitis and sometimes bleeding piles. If we have lump only, that's most likely will be skin tag, and that's representation of the anal fissure, or perianal warts sometime, or anal carcinoma or neoplasm. We have to think about it. If it is pain and lump, it would be perianal hematoma or perianal abscess or thrombosed bile, which is causing the pain and the lump. If there is pain and lump and bleeding, we have to keep in mind the piles or the hemorrhoids, whatever the degree of it, would be second or third degree or fourth degree, or ulceration of perianal hematoma of the external piles. If there is bleeding alone, we have to think about internal piles. We have to think about colorectal polyps. We have to think about the colorectal neoplasms like the carcinoma and that stuff. So this is giving some clue about the presentation, about what we have to think about. The most common conditions which we are facing in our hospital or in our casualty usually would be either piles or anal fissure or an abscess. Those are the most common three presentations or three diagnoses which we have to keep in mind. If we are starting by the hemorrhoids, we have to differentiate between the grades of the hemorrhoids. If it is first degree, it will be definitely not palpable, and it could be definitely felt by the digital examination. If it is second degree, it will be a little bit prolapsed, and it is going to be reduced on its own. The patient will tell you that I have, during the defecation, I'll have some swelling around the anus, but after finishing the defecation, it will be reduced on its own. The third degree will be definitely need some help from the patient after passing the stools. The prolapsed piles has to be pushed by the finger to return back on its own position. And the fourth degree, that means it is prolapsed outside the anal canal and it is not being reducible. So the first and second degree, you can definitely prescribe some treatment for them, and the patient could get a benefit from it. The most important thing, the diet regime. The diet regime, you have to ask your patients to increase the fibrous intake, and that will make definitely the stool or the passing the stool as bulky and soft, and that will definitely help in controlling the piles. If it comes to second or the third degree and the fourth degree, the patient has to be referred definitely to the surgical clinic, because most of the time he will be in need for some sort of surgical intervention or some intervention, whatever it is. I'll talk about the treatment of the piles. Before leaving this slide, I have to explain this is most of the anal cases which we are facing here on the left-hand side. It's either a rectal polyp, which is causing some bleeding. And we spoke about the piles, either first and second degree. And here we have the fourth degree, which is being prolapsed and thrombosed. Or we might have some abscess or perianal abscess, like this one would be perianal abscess, and this one will be ischiorectal abscess. And here, or sorry, that will be ischiorectal abscess, or this also will be ischiorectal abscess. And there is some transsphincteric abscess would be in this area here. The third case would be the anal fissure, which is causing the pain. This is a photo of the fourth degree piles on the right-hand side. That's definitely needs hospitalization and needs intervention. So when I see this kind of picture, I'd say I have to call the on-call surgeon to admit the patient and to deal with the case. What are the algorithms for the management of the hemorrhoids? I have mentioned that the first and the second degree would be definitely treated or initiating the treatment by the GP. If there is no prolapse like the first degree and the second degree, most of the time, you can increase the high fibrous intake. You can give him some suppository for the antihemorrhoidal with a steroid or without steroid, according to the inflammatory status of the piles itself. And that's usually being treated by injection by the endoscopist or by the surgeon with the sclerosing material. Or the second option will be sometimes band ligation. But definitely in the first visit in the casualty, or in the GP clinic, we have to help the patient to increase his fibrous intake, and I'll give him some anti-hemorrhoidal cream or suppository. If he's in constipation status, I can give him some laxative and some analgesia if he needs. If he's having prolapse, he will definitely need for procedural treatment, whatever the situation is, either grade 4 or grade 3. So he will be referred to the surgeon and he will examine him definitely. Either he will go for some excisional surgery or some sort of other intervention like the sclerosing material injection or the band ligation, or sometimes the heat therapy, which is important in that. So the bottom line here, if I have a patient diagnosed as a first degree or a second degree, I can give him some medication and I can call him back for the surgical clinic after 2 weeks of using the medication and having the diet regime. If he's having third degree or fourth degree, I have to refer him as soon as I can to the surgical clinic, and that will be the end of the story of the hemorrhoids. The second topic, or the second thing, would be the fissure in anum. And the patient is usually coming to you, the main complaint for him will be the pain. Sometimes you're saying that I have a bleeding with the constipation status, and the bleeding is usually mild and it's usually seen on the tissue papers and that stuff. It will be bright red, mild amount of blood, but the main complaint would be the pain. Examination here is very important. I know that it's painful for the patients, but at least when you are just exposing the anal verge and having an inspection of it, when you are seeing this skin tag just at 6 o'clock or 12 o'clock, mostly in the females, and just opening the anal verge a bit, you will find this kind of fissure or lacerated area in the mucosa below the dentate line. And that's definitely enough to diagnose this. The most common site will be at 6 o'clock in the male, and in the female, sometimes with the pregnancy, it would be at 12 o'clock. Definitely, it's very painful to do a digital examination for this patient. You make sure that whenever you are not able to do this kind of peri-anal or digital examination, you have to think about the fissure more than anything else. What's the causing of the anal fissure? It's definitely the constipation, which is the most common cause or the only cause which we have to think about. The patient is usually telling you that I had a constipation, and while I am passing the bowel motion, I had severe pain in that time, followed by having some blood on the tissues, or when I'm washing the area, I found some blood. And this kind of pain persists for few hours, sometimes several hours after the defecation. And since having this kind of constipation or this kind of bowel motion with the hard stools, every time I'm going to the bowel to open the bowel motion, I have the same experience of the pain and the same experience of the mild bleeding. So, as I have mentioned, the examination is very important to differentiate between the other causes of the pain, like the abscess or the prolapsed thrombosed piles, and you can start the medication or the treatment for the patient. What kind of medication which I have to use in this kind of patient with the anal fissure? Again, the general idea or the general measures for every anal complaint patient, he has to have a high fibrous diet. I would advise him definitely to increase the fibrous intake by having the fresh fruits, fresh vegetables, brown bread better than the white bread, and the water. Usually they are, or all of us are forgetting about the water, and everybody or every person is in need for at least 2 to 3 liters of water or juice or whatever it is during the daytime. Stool softeners, just to make the stool easier to pass, it's advisable to be used also in all the cases of the anal pain. As I mentioned, drinking water is mandatory, and to sit in a warm bath for at least 10 to 20 minutes. That's definitely to decrease the congestion of the area and decreasing the pain and soothing the area, sometimes helping in controlling the pain. These are control measures. I would say that it's being used in every single patient with any anal complaint like piles or fissure or even sometimes the proctitis or the proctal ulcer or rectal ulcers and that stuff. The medication which is being used specifically to the anal fissure. The lidocaine is local anesthetic, and it's important to be mentioned to the patient that he can use it for 3 or 4 times or 5 times a day, especially before and after the opening the bowel motion. That's definitely giving them a chance to decrease the pain intensity. The metronidazole. The metronidazole is being used or prescribed for the patient with the anal pain, especially the fissure, because most of the times the tunneling of the anal fissure having some anaerobic infection, and this kind of anaerobic infection needs to for at least 10 days from the start of the symptoms. And there was some study done in Dublin, I have, as far as I can remember, that was in 2002 or 2003 in St. James's Hospital. And they found that the use of the metronidazole is decreasing the pain in the anal canal. It was ambiguous mechanism, but it has been recommended, I do remember, for using the metronidazole for those kind of cases. I have to use anti-inflammatory and analgesia for those patients just to control the pain. The most specific thing we are using nowadays is the nitroglycerin paste, 2%, and that's definitely relaxing the anal sphincter or the involuntary anal sphincter. I have to mention to the patient that when he's using this kind of nitroglycerin paste, he might experience some sort of headache or so, but he has to tolerate it. I have to keep in mind that the guys with the hypotension usually should be avoided this kind of nitroglycerin or decreasing the concentration of it from 2% to 1%. It's being prepared in our pharmacy here, and it's being disposed to the patients as a local treatment for the fissure. Some people trying or using the calcium channel blockers also just to relax this kind of sphincter, and some people using the botulism or the botulinum as an injection for the site. But I'd say what we are using here or our use for the fissure is the nitroglycerin. Prescribing those kind of things to the patient, I'd say you have to give him a chance to use them for at least 2 weeks, and then he will see the surgeon. That will save him a couple of visits to the surgeon. If I'm seeing him today in the casualty or the GP clinic, and I'm giving him only some sort of analgesia and sending him to the surgical clinic on as soon as possible, which is in a few days or so. So you will delay the treatment to be initiated, and the surgeon will start this kind of treatment for another 2 weeks, and he will see the patient for the second time, which is the third time in the hospital, to go ahead if he is not responding to those kind of for surgery, or if he is responding to discharge him. I have to mention here that those medication usually being effective in the treatment of the fissure in anal, provided that patient is committed not to have a constipation, to change diet habit, that stuff. Most of are responding, I would say 60 to 70% are responding to this kind of treatment, and 30% or 40% might be in need for surgery if they are not responding to this kind of medication. So this is about the fissure in anal. The third most common presentation would be the anal abscess and the infected anal fistula. The anal rectal abscess originates usually from the infection arising in the cryptograndular epithelium lining of the anal canal and the internal anal sphincter is believed to be served normally as a barrier to the infection passing from the gut lumen to the deep perirectal tissues. The presentation of the anal abscess is usually with building up pain. The guy will start to say, or the patient will start to say to you, I have a perianal pain or pain around anus for the last 2 days. It starts a little bit slightly, and then it's building up and increasing. Sometimes he'll say that I feel there's some swelling in the around the anal canal, but the most bothering thing is the pain. Again, while examining this patient, you have to look at the anal verge. There is no skin tag and there is no fissure. You can do the digital examination here, but most of the time, the pain and the tenderness is just around the anal verge. When you are feeling tenderness around the anal verge, you don't need to wait for the fluctuation. You don't need to wait for the skin changes because it will be very late. So when you have this kind of pain around the anal verge and this history, which is starting lightly and building up intensity for 2 days or so, you have to power the anal abscess. So I'll get back to the anal abscess again. As I said, we shouldn't wait for having any skin changes. We shouldn't wait for the fluctuation of the area like the other sides of the body for the abscess to be diagnosed. In the perianal abscess, once you have pain and tenderness, sometimes there is bulge or not around the anal verge, and there is no fissure in anal, and you palpate it, there is no prolapsed piles or so, you have to think about the abscess and it has to be drained. As I said, there is no rule for the what you call the antibiotic treatment before the drainage whatsoever. So this is about the abscess and the infected sinus. Let me just get you about some sort of history about the perianal fistula. It's one of the most ancient disease which has been discovered since the time of Hippocrates. So it's almost 2 millenniums or so. And he had made reference to the surgical therapy of the fistula himself, Hippocrates. And he was the first person to talk about the seton treatment or the seton management for the fistula. In the 14th century, I'd say John Andrine is a British surgeon also. He described the fistulectomy or the fistulotomy, I should say, or the laying open of the fistula with usage of the seton. And the most recent guy was in the 19th century, that was Frederick Salmon. Frederick Salmon is one of the guys who have established the St. Mark's Hospital in London, and this is the hospital which is very specialized and eminent hospital in treating the anorectal conditions. And Mr. Salmon was one of the guys who started the modern treatment and putting the modern treatment for the fistula in ano. Again, the most common cause for the fistula in ano would be the predisposing perianal abscess and the infection of the crypt canal or the crypt glands of the anal canal itself. And the most important thing which I have to mention here, if we have neglected drainage of an abscess, most likely it will be turned into fistula. So diagnosis of the perianal abscess as early as we can and draining it properly would save the patient the complication of the abscess or part of it, I should say, not to develop some perianal fistula. When I have a presentation with the perianal fistula infection, that means the patient is having pain and having some bulge in the area of the opening of the fistula itself, and he needs to be intervened surgically also. If it is draining, that's fine. He can take some antibiotics and he could be seen in the clinic in due course, in as soon as we can, like 1 week or 10 days or so after using the antibiotic. But if it is definitely bulging and severe pain and not draining, that means you have to call the surgeon on call just to deal with it. So the treatment of the abscess, as I mentioned, just call the on-call person. I wouldn't be inclined to wait to see this kind of appearance of the abscess in the anal area at all. Once I have a pain and tenderness without having this kind of appearance, because this kind of appearance, that means I have waited for the patient 3 or 4 days to develop this kind of picture, to be honest. If I discovered it from the first day when he's presenting or the second day he's presenting, it would be very good to just pick it up and drain it properly, and that will save him another journey for the OR if he's developing fistula like. So please Don't wait to see this kind of picture in the patient with perianal abscess to diagnose the abscess. The most important diagnosis would be the pain and the tenderness around the anal verge. And if you are doing the digital examination, it could be a little bit also tender from one of the sides, like 9 o'clock or 3 o'clock from inside the anal canal. And there is no manifestations of piles or any fissure in that area. So in that case, you have to think about the anal abscess or the perianal abscess. The other causes of the anal pain, which is rare presentation, but what we have mentioned are the three main causes which you are usually definitely seeing in your department. But at the end, I have to mention about the rare causes which you can face in the casualty or the GP clinic, and that needs definitely some sort of investigation and examination by the surgeon. Inflammatory bowel disease, like the ulcerative colitis or the Crohn's disease or the proctitis from a solitary ulcer, if there is any minor injuries, which sometimes happening in the kids and that stuff during the play, if there is fecal impaction in the elderly patients, usually that's one of the causes of the pain, but it's easy to diagnose by doing the PR examination. The levator ani syndrome and the muscle spasm, which we call proctalgia vogus. In this kind of condition, it's severe, sharp pain happening all of a sudden without any predisposing factor, and it's going on its own. Most of the time, it is related to the psychiatric or psychological status of the patient, and it's going on its own without having any intervention in that kind of thing. Malignancy is an important topic, and we have to think about it seriously at the bottom of the causes, like, but still it's there. I have to mention one case I have met while I was a senior registrar. I would say that in early 2002 or 2001 or so, one young chap presented to the casualty and diagnosed as a perianal abscess. He was 25 years of age, and I went to examine him, and I found that there is pain and that stuff, and I got him to the OR. And while doing this kind of incision and drainage, I found that it is very necrotic, offensive material. And unfortunately, this young chap is only 25 years of age and has been diagnosed as an invasive anal carcinoma. And it was definitely a late stage to present itself like this. So it has to be kept in mind, but it is not a common presentation. It's definitely has to be diagnosed during the procedure itself. I wouldn't say that you can pick it up without having the diagnosis if it's presented with pain like. So those are the most common causes and the rare causes of the anal condition. As I mentioned, the bottom line here is to think about what's the differential diagnosis from the first three causes of pain, which I have mentioned, either the hemorrhoids, anal fissure, and perianal abscess and infected perianal fistula. Those are the most common four causes you are going to face in your clinic. And I'd say managing them is very easy, as I have mentioned, and initiating the treatment is very important not to lose some few days until the patient being seen in the clinic in the near future or so. So that's it. I hope that I have mentioned most of the causes or the most of the things, and the open is floor for questions if you don't mind.